Sir, please start in 3, 2, 1. Please start. So we are.
Good evening and welcome everyone to Lung Cancer Treatment Updates 2024. With immense pleasure, I would like to invite Dr. Ajay Sharma sir, founder and director and medical head medical oncology, AS Lifeline Cancer Care Center. Over to you, sir, for the welcome and introduction. Ajay sir. Hello. Ajay sir, are you there?
Yes, I am here only.
Sir, can you please do the welcome introduction?
Okay, sure. So, good evening, everyone. And in continuation to our series about the live webinars, and most of the time we are talking about the lung cancer and any recent updates about the lung cancer, may be surgical, medical, or any radiation in the field of radiation oncology also. So we keep on discussing the new things. So to continue with the series, here today we will be discussing again about the recents in the lung cancer and what are the recent treatment updates, and including few of the important trials we will be discussing. So in this, the few eminent doctors would be joining. First of all, I welcome Dr. Nitin. He is a medical oncologist, passed out from All India Institute of Medical Sciences, and a very good friend of mine. So he will be talking about the lung cancers, and a few of my junior colleagues are also there. Dr. Madhur, one of the, I think, respected doctor in Delhi. So, and followed by Dr. Nishan. So he is also one of the good and great clinical acumen he is having. So he will be again discussing few recent updates about the lung cancer. So to start with, I think I'll start up with the presentations about the ADAURA trial. So I request the who is the organizer over there. I won't be able to share my slides. So on my behalf, if somebody can share my slides so that I can start.
Tech support, please share Ajay sir's screen.
Great. So I can see my slides over there. So the topic for the discussion is the osimertinib, its role in the early mutated EGFR populations in the non-small cell lung cancer patients. So we call it as the one of the major trial, and the landmark trial in the lung cancer is the ADAURA trial. Next. So we see 1 in 3 patients with the lung cancer, they present with the resectable disease. And if we see lung cancer is the leading cause of the cancer death, and it accounts 1.7 million deaths every year. And many deaths are because of the breast, prostate, and colorectal cancers combined also. And if we see only the lung cancer, 85% of all lung cancer cases, within estimated 30% of the patient present with the resectability at the time of diagnosis. So localized and early stage is the stage 1B, whereas the regional or locally advanced, we call it as a stage 2 and stage 3A. Next. Outcomes, if we see in the early stage of the lung cancer, they need to be improved, because we see surgery is the mainstay of the treatment in patients with the early stage lung cancer, and the adjuvant platinum based chemotherapy is recommended who are resected stage 2 and 3A lung cancer, and selected patients of the stage 1B disease also. Yes. So based on the limited number of studies, the prevalence of EGFR mutation appears broadly similar across the disease stages. In the Asian, overall prevalence is 30 to 40%. In Caucasian, it is 10 to 20%. So if we see prevalence for each stage, so here is the chart. And if EGFR TKIs were available in the resectable setting, a similar proportion may be able to benefit compared to the advanced setting. Next. The adjuvant therapy with the osimertinib in stage 1B to 3A, the population who are EGFR mutated and who are after complete tumor resection. This is for the patients we have a ADAURA trial. Next. So it is a phase 3 double-blind study design, and the stratification is based upon the stage, that is whether stage 1B versus 2 or versus 3A, and EGFR mutated, whether it is a 19-del exon mutation or it is L858R mutation, and Asian versus non-Asian. So osimertinib with the dose of 80 mg in the ratio of 1:1 was given, and the placebo once daily was given, and the planned treatment duration was 3 years. Next. And not to forget, the primary and secondary endpoints was the progression-free intervals and overall survival. So here is the inclusion criteria. The important things were they must be post-op stage 1B to 3A and confirmation of the mutations and standard post-op adjuvant therapy. At least 4 cycles were allowed but not mandatory, and complete surgical resection of the tumor, and an MRI and CT scan of the brain is the necessity, and performance status should be 0 to 1. And prior treatment with radiotherapy, pre-op chemotherapy, if they are treated with EGFR TKIs, and segmentectomy are the wedge resections, and time was very important, and the cardiac criteria if having some QTC prolongation. So with ILD, these were the few of the exclusion criteria. Next. So baseline characteristics we see, we included both male and female with the age. Median age was in the years, it was somewhere around 64 in the osimertinib and 62 in the placebo arm. Both smokers and non-smokers with equal proportion were kept. Asian, non-Asian. Performance status, as I said, was 0 to 1. And the AGCC staging was according to the 7th and 8th edition. And histology, adenocarcinoma, and mutation was very important, like I told 19-del and L858R, and whether adjuvant chemotherapy given or not, this is a ratio with the osimertinib and the placebo. Next. So updated primary analysis in stage 2 and 3A, the median disease-free survival in months was osimertinib. If we see, it was the we see there was a statistically significant this hazard ratio was seen, and this is the chart which I am seeing where we can very clearly see the median DFS was benefited. Next. And this is updated primary analysis in the overall population. Again, benefit was seen in the median DFS. Next slide. So 4A DFS was consistent for the osimertinib arm across the disease stage. And if we see, the hazard ratio was significant in all the stages, stage 1B, 2, and 3A in osimertinib arm. Next. And the updated DFS across subgroups in the overall population in the forest plot, we can see the overall the stratification in whether the subgroups were male or female, age less than or more than 65 years, smokers, non-smokers, Asian, non-Asians, and stage 1B, 2, and 3A, and the mutations, 19 deletion, and sensitivity to L858R, and adjuvant chemotherapy, yes or no, all the patients in the subgroup, we see a benefit of the osimertinib. Next. So early snapshot, overall survival in patients. Patients and investigator remained blinded to the treatment in order to facilitate the assessment of overall survival at the maturity. And we see that the osimertinib compared to placebo, we see that the median OS at months, they were almost comparable. Next. So these are few of the important trials with the TKI in the adjuvant settings, and DFS but not OS benefits have been demonstrated. To name a few of the trials are Select trial, Radiant trial, Ivan trial, adjuvant CTONG 1104, and BR 19 trials. So few of the trials showed the benefit, whereas a few trials didn't show the benefit. So specifically today we are discussing the ADAURA trial. The next. The type of recurrence is a key consideration in resected non-small cell lung carcinoma. Local versus distant recurrences has an impact on the outcomes post-surgery. So, the preventing CNS recurrence is an area of unmet need. And CNS is the common site of distant recurrence among patients who are having positive mutations. And osimertinib has shown clinically significant exposure in the brain compared with the other TKIs, and has shown a great penetration to the blood-brain barrier. So this is very important point for the osimertinib, that the blood-brain barrier is crossed by osimertinib, and we see the effect in the brain also. The advanced in the advanced setting, first-line osimertinib demonstrated superior overall survival with the osimertinib. So the ADAURA, the type of disease recurrence we see, 11% of the patient in osimertinib arm had DFS event, and versus 46% of patient in the placebo arm. And majority of the patients in the osimertinib arm had a recurrence only, with only 38% having metastatic recurrence compared to the 61% patients in the placebo arm. Next. The sites of disease recurrence we see, the most common first site of recurrence were the lung 12%, lymph node 6%, CNS 6%, and osimertinib group, and the lung 26% and lymph node 17% and CNS 11% in the placebo arm. Next slide. The updated CNS DFS events in the stage 2 and 3A disease. Again, if we see the median CNS DFS in months, there was a benefit with the osimertinib. Next slide. Coming to the safety of the drug, the duration of treatment was 3 years, and median total duration of exposure with the osimertinib was approximately 36 months, and placebo it was 25 months. And osimertinib, we had not that severe any side effects was seen, and it was a well tolerated drug, and the grade of events were hardly, it was more than anywhere, it was more than 2. So and there was less of the discontinuation, there was less of the dose reduction, there was less of the dose interruptions, and overall adverse events were very rare. Next. The adverse events, more than 10% of the patients, if we saw, they were diarrhea, paronychia, dry skin, pruritus, cough. I mean to say, they were very casual events, which were very well manageable that we saw with the osimertinib. And the ILD was reported in 3% of patients in the osimertinib arm, and QTC prolongation was reported in 9% in the osimertinib arm and 2% in the placebo arm. So these are the two areas where we should be a little bit careful. Next. So chemotherapy use and outcomes from ADAURA. Osimertinib as adjuvant chemotherapy for resected EGFR mutated non-small cell lung cancer. This is a paper, and this again is showing the authenticity of the drug in the adjuvant setting. Next. So adjuvant chemotherapy use, if we see, overall 60% patients received adjuvant chemotherapy for a median duration of 4 cycles, and majority of the patients received platinum-based chemotherapy, mostly in stage 2 and 3A. And adjuvant chemotherapy was more frequent in age less than 70 years. So this is the chart in which we can see the number of patients who received the adjuvant chemotherapy, which was 26% in stage 1B, 71% in 2, and it was touching 80% in stage 3A. Next. So DFS in patients with and without adjuvant chemotherapy. So with adjuvant chemotherapy and without adjuvant chemotherapy, if we see the curves with the osimertinib and the placebo, so we can hardly see any difference. So it means that it benefited in both the subgroups, whether the patients has received the adjuvant chemotherapy and also who has not those who has not received the adjuvant chemotherapy. Next. So again, if we come to the subgroups, we'll see that it benefited in all the stages, stage 2 and 3, stage 1B, and stage 2 with and without, I'm saying, and also in stage 3A. So there was a benefit, clinical meaningful DFS benefit in with osimertinib was observed with or without adjuvant chemotherapy, regardless of the disease state. Next. So stage wise, if we'll see again stage 1B, B, with and without adjuvant chemotherapy, there was a benefit. Next slide. In stage 2, again, in both the subsets, there was a benefit. In stage 3A also, the benefit was seen in both the subsets of with and without adjuvant chemotherapy. Next. Next slide. So patient reported outcomes from ADORA. There was a benefit in all the these biographics which we have discussed. And coming to the quality of life. So quality of life, if we see the osimertinib maintained the QL in all the patients as compared to the other TKIs. Next. And compliance and health survey over time, they were very well seen with the osimertinib arm as compared to the placebo arm. Next. So next slide. I think let us skip this slide, physical and mental components. So I think not a great thing to discuss here. So coming to the summarization, in this DFS analysis of osimertinib versus placebo, we saw overall there was a 77% reduction in the risk of disease or death with the adjuvant osimertinib versus placebo, and median DFS was 65.8 months and 21.9 months in the placebo arm. There was also 73 reduction in the risk of disease recurrence or death with the osimertinib, and the DFS was improvement in DFS was seen in both the prior who has received the adjuvant chemotherapy or not, and the osimertinib demonstrated a clinically meaningful improvement in the CNS disease-free survivals, and the safety profile was very well established with the osimertinib. So these updated data reinforce the adjuvant osimertinib as a standard care of patients with the mutated EGFR populations of stage 1B to 3A non-small cell lung cancers after the complete tumor resection and with or without adjuvant chemotherapy. So with this, I conclude my talk. So I give an opportunity to my colleagues and the next speakers to please share your views about this. Thank you.
Thank you, sir. It was an amazing talk. For the next talk, I would like to invite Dr. Madhur Vats. He will speak on overview of lung cancer. Over to you, Madhur, sir.
Hello, Rishabh sir.
Just a minute. I'm calling Madhur sir.
Yes, madam
Yeah,
is joined.
he is joined. Dr. Madhur sir, can you hear me?
Am I audible?
Yes, sir, you are audible, sir.
Good evening, everyone. Can you please share my slide, please? I'm unable to share it here.
Tech support, please share the slide. Thank you.
So I will be talking about the overview of lung cancer. So according to the new, next slide, please. According to new Globocon WHO 2020 data, so total number of lung cancer is approximately 2.5 million, and total cancer deaths will be approximately around 0.3 million per year. And the prevalence is on the number fourth. First will be breast, colorectal, prostate, and followed by the lung cancer. And mortality will be high mortality. Lung cancer is having the highest mortality here. Next slide, please. Okay, so total number of, hello? Yeah, so total number of cases will be approximately 72,500, and it's all the data I have told you. And next slide. So, what all investigations we do for staging? So, first is bronchoscopy, followed by chest X-ray, CECT chest, PET scan for extent metastasis, and EBUS, mediastinoscopy, and MRI brain. MRI brain because according to new recent updates, CNS is the most metastatic thing after this. Next slide. CECT versus PET scan for staging. So lymph node more than 10 along with short axis predictor of malignancy. CT scan alone has so CT scan have low specificity and sensitivity of sensitivity of 55% and specificity of 81%. And PET scan having high specificity and sensitivity of approximately 80 to 90%. Next slide. So, so we have three type. So based on histological types. Okay, so we have four types: adenocarcinoma, squamous cell carcinoma, and small cell carcinoma, and large cell carcinoma. So non-small cell carcinoma comprise of adenocarcinoma, squamous cell, and large cell. So centrally located tumor will be the basically uh, hello. Previous slide, please. Previous slide, please. So this is all the staging we have to do. It's on the TNM staging. So T1 will be less than 3 centimeters surrounded by the lung visceral pleura, and T2 is more than 3 to 5 centimeters in main bronchus without carina, and the T3 will be more than 5 to 7 centimeter in greatest diameters, and T4 is more than 7 centimeters. And it will be positive. It will be shown positive on PET-CT and negative on CHCT. Next slide, please. So these are all the stages which I have told you right now only. So it will be more. Next slide, please. So I have told you the histological breakdown is squamous cell, non-squamous cell, large cell adenocarcinoma, and on based on the molecular pathology, it's EGFR, ALK, and ROS1. These are basically the mutations part. Next slide. Molecular. So these are all the mutations, KRAS mutations, EGFR, ALK, ROS, BRAF, and RET. Okay, so in non-small cell lung cancer, molecular testing should be standard. So based on these mutations, we categorize them. Next slide, please. So in stage 1A, so no lymph nodes will be there. So we do neoadjuvant and adjuvant chemotherapy and stage 1 and second A. Okay, we do neoadjuvant chemotherapy, and on stage 2B, we do adjuvant chemotherapy, and on stage 3A and 3B, so we do neoadjuvant chemotherapy, adjuvant chemotherapy, and sequential chemotherapy plus radiotherapy. But nowadays we are adding immunotherapy also in this. Next. So these are the findings at the surgery after the surgery. The resected margins. Okay, negative margin, no residuals will be left. Positive margin, microscopic residual tumor will be there, and positive margin, microscopic residual tumor. So after resection, we do after initial treatment. More than half of the patient with resectable non non small cell lung cancer experience recurrence within 5 years, and 40 to 50 remain cancer free, and 50 to 60% reoccur. So after surgery plus radiotherapy, with a combination of surgery and radiotherapy. Next. This is a meta-analysis on efficacy of the neoadjuvant chemotherapy, and it's clearly shown like it's very much beneficial for it for the stage 1 from 1B to 3A, and neoadjuvant in combination with neoadjuvant chemotherapy and adjuvant chemotherapies. Okay, so these are the charts. It's very much beneficial for it, and it's quite the efficacy is quite high. Next. So these are as Sir have told about the ADORA trials. These are the targeted therapies now moving to early stages, and with introduction of EGFR TAI, DFS is improved from 44% to 44% in plebo to 90% in EGFR TKI arm at 24 months, and osimertinib versus placebo. This is a chart of, and it's now possible to further improve survival in completely resectable stage 1A, 3, and non-small cell lung cancer. Next. Atezolizumab is a monoclonal antibody, as you all know, an improvement in DFS as well as adjuvant setting, and showed an improvement in survival in adjuvant setting in patient who had PDL1, and such therapies will improve survival rate in non-small cell lung cancer. Next. So lung cancer radiation in 2020. So Advanced technology have led to safer treatment and intensity modulated radiation therapy (IMRT) have been shown to improve survival of patients with stage 3 NSCLC to thyroid tumors, and we use it in thyroid tumor also, and reduce those to heart with lower rates of grade more than three pneumonitis, increase dose to heart associated with high risk of death in stage 3 non-small cell lung cancer. Next. So we so there is SBRT also, stereostatic body radiation therapy versus conventional fractionated external beam radiation is typically a IMRT technique only. And so we SBRT we usually do in inoperable cases early in when in the early stage of non-small cell lung cancer and hepatocellular carcinoma. Next, 4D CT planning. These are all the cancer radiation. 4D CT planning allows us to margin around tumor to be minimized. Image guided radiation therapy (IGRT) ensures accurate target coverage for every treatment while reducing margins need to cover tumor and adaptive radiation, creating a new radiation plan after tumor targets. End result small target volume with lower dose to normal tissue, including lung, esophagus, and the heart. Next. These are the contemporary radiotherapy techniques in stage 3 non-small cell lung cancer, long-term OS results from RTOG 0617. So phase 3 RTOG 0617 evaluates standard dose versus high dose CRT plus minus cetuximab in stage 3A or 3B. 5-year OS 32% with high quality standard dose radiation therapy. So as I told you in the earlier slides, like nowadays we having better results with the immunotherapy added to CRT backbone. Next. So chemotherapy with and without radiotherapy, okay, standard. So stage A1 we need to observe it. Stage 1B, okay. So the multidisciplinary team consult to discuss observation versus chemotherapy. Stage 2B, chemotherapy only, and stage 3A, chemotherapy plus, and we can add radiotherapy also, sequential chemotherapy. Next. So these are the double-blind specific trials called as specific trial, randomized and placebo-controlled phase 3 trial of consolidation, durvalumab in unresectable NSCLC. So durvalumab demonstrated 42.9% OS at 5 years in comparison to historical OS in unresectable stage 3 NSCLC at 5 years in 15 to 25%. And it's time for so emerging treatment nowadays targeted therapy and immunotherapy for non-small cell lung cancer. Next. So as we can see from 2015 to 2021, so atezol- atezolizumab and nivolumab, and so these are all the PDL1 and PDL monoclonal antibodies. These works on this. No GFR or ALK mutations, and if there is no ALK and EGFR mutations, so we use semiplatinib and also ROS1 mutation, also targeted therapy if GFR or ALK mutations are there. Next. So these are the approved therapy in breast cancer, upcoming in non-small cell lung cancer also. So there will be, yeah, next. CAR T cell therapy, a new era in cancer immunotherapy. So they take this, they make the cells and increase the immunity. Next, key takeaway: the management landscape is fast changing in non-small cell lung cancer. Newer therapies have a huge potential to improve survival, especially when detecting in early stages. The OS has improved across various subtypes with molecular alterations. The ease of oral pills over infusion in case of targeted drugs is an added advantage. Pulmonologists will play a huge role in early diagnosis, hence it's crucial to involve them in non-small cell lung cancer tumor boards. Next. Thank you everyone for listening.
Thank you, sir, for such an amazing talk. For the next talk, I would like to invite Dr. Nishant, sir, to give his talk on how do I diagnose and manage lung cancer. Over to you, sir.
Good evening to all respected sir. Myself, Dr. Nishant. I am here to represent a presentation on lung cancer, its diagnosis and management. I would like to start with initial presentation of non-small cell lung cancer. Non-small cell lung cancer, it encompasses a wide range of disease which stages between first to fourth and may present via various routes like a symptomatic patient identified via screening assessment of risk factors, symptomatic patient referred by primary care physicians, patient identified after incidental finding on imaging scan for other condition, and a symptomatic patient with emergency presentation. Early diagnosis allow for potentially curative treatment. Evaluation to diagnose and determine.
Sir, your screen is not visible if you are sharing your screen.
One second. Now it is visible.
No, sir, it is not. Yes, sir, it is now visible. Can you make it full screen, sir?
Yes. I would like to continue. Evaluation to diagnose and determine the stage of a non-small cell lung cancer. The aim of diagnosis is to establish the presence, extent, and stage of disease, which allow the most appropriate treatment. It depends on clinical and laboratory evaluation, imaging and sample acquisition, pathology, diagnosis and staging, biomarker testing, and treatment selection. Clinical and laboratory evaluation. A clinical and laboratory evaluation provide information to support clinical staging, like medical history, physical examination, laboratory evaluation, like CBC, blood cell count, and electrolytes. In medical history, we include complete medical history, risk factor, comorbidity, and for physical assessment, we include sign and symptom, performance status, reported weight loss, which indicate various diseases like tuberculosis and all, and a laboratory evaluation. It depends on blood cell count and electrolyte, calcium and alkaline phosphatase, and LFT liver function test. A clinical and laboratory evaluation may also contribute to determination of surgical eligibility and resectability in patients with early stage disease. Imaging tests are used to look for tumor in the lungs, like imaging is used to determine the position, size, shape, and extent of the tumor and access lymph node involvement for clinical staging before treatment. Imaging procedures are selected according to different patient characteristics as determined by initial tests such as patient history and physical examination. Generally, techniques involved in lung cancer. It is a chest X-ray, CT, PET, and PET with PET-CT with contrast. Additional imaging procedure may be used for metastatic workup, which include MRI and bone scan. Mostly chest X-ray imaging is used to look for suspicious mass in the lung. X-ray images are produced by beam that go through the body and project a picture of the organ and bone inside the chest onto film. Generally, chest X-ray it is often first imaging technique which is used to detect mass in the lung. If a suspicious mass is detected by X-ray imaging, additional tests may be performed to correlate and find the disease. Findings suggestive of lung cancer on chest X-ray should be further evaluated via contrast enhanced CT. CT scan provide information on the primary tumor. CT captures a series of cross-sectional X-ray images of the chest and it combines them onto a detailed image. Chest CT, the scan that are standard imaging technique that should be used in all patients with suspected lung cancer. CT scan are more sensitive than X-ray and are used to determine the position, size, shape, and extent of a tumor, and to assess whether lymph nodes are involved or not involved, it is large or small. CT findings are used to access clinical stage, and CT findings determine whether additional imaging needed or not, or guidance is needed, or the choice of optical site for tissue sampling for pathology, particularly in regional lymph node involvement. PET or PET-CT provide additional diagnostic and staging information. PET uses a radioactive molecule injected into the blood to detect rapidly growing cancer cells. PET scan can help to confirm the clinical diagnosis of primary lung cancer, but alone have poor anatomic definition of suspicious lesions. PET is often combined with CT scan to show the distribution of radioactive tracer with more detailed anatomic image. And NCCN and ISMO recommended combined PET-CT for all clinical access stage 1 to stage 3 patients to detect mediastinal disease and distant metastasis. PET and PET-CT imaging findings are not conclusive and require pathological confirmation. MRI is generally used to screen for brain or spinal metastasis. Generally, MRI scan use radio waves, which is a strong magnet to produce detailed image of the soft tissue in the body. NCCN recommend brain MRI for patient initially clinically assessed as stage 2 and stage 3 and optionally for stage 1B. It is not recommended for stage 1A. ISMO guideline state that brain MRI might be useful in patients with stage 1 and stage 2, in which disease is considered for curative therapy, and it is indicated in all patients with stage 3 disease. Contrast enhanced brain MRI, it is preferred over CT for evaluation of the brain as it is more sensitive. And thereafter, a bone scan help determine whether the lung cancer has spread to the bone or not, whether the involvement of the mediastinum or ribs. And for bone scan, a small amount of low-level radioactive material is injected into the blood and collect mainly in abnormal areas of bone. Bone scan are needed when PET scan results are unclear. Bone scan are considered an integral part of staging patient with potentially operable NSCLC. Whole body bone scan are useful in staging patient with NSCLC. Patient with metastasis NSCLC could be understaged due to asymptomatic bone metastasis and may not benefit from surgery to remove the primary cancer. Pathological testing to guide treatment. Actually, final diagnosis and classification and its subtypes required pathological assessment of the tumor cell under the microscope. It is a histological examination and may also guide genetic analysis, which is on molecular diagnosis based. Diagnosis and classification may be performed using biopsy tissue in patient with advanced disease or resected tissue in patient with early stage NSCLC with lung cancer. The initial pathology report is prepared by a pathologist either on site or off site. Turnaround times vary, but results should be available within 2 days to 1 week. Identification of non-small cell lung cancer cell and histological subclassification during histological examination. Generally, histological subclassification of NSCLC is a key factor for treatment selection and has been identified as an important predictor of treatment response. The main histological subtypes include adenocarcinoma, which is of 55%, and squamous lung cancer, which is of 34%. Generally, it is a non-small cell lung cancer. Tissue sample takes from patient with non-small cell lung cancer, which is first proceed by the gross examination, which involves examining the specimen by looking at measuring or feeling the tissue, and fine sections of the sample are cut before undergoing closer analysis with a microscope. A pathologist will then look at the size and shape of cell and their nuclei and overall arrangement of cell. Lung cancer cell can be identified and subclassified based on their cellular characteristics. The next topic is staging is essential for clinical decision, which making and treatment planning for non-small cell lung cancer. Mostly staging provide a consistent and unambiguous method for clinicians to describe and convey the extent of disease and to predict prognosis. Clinical staging, it is based on pre-operative diagnostic evaluation, including clinical imaging and pathological analysis. It determines tumor size and position, regional lymph node involvement, and presence of distant metastasis. And it also allows a multidisciplinary team to evaluate the most appropriate initial treatment approach, including the surgical technique, if possible, and the use of neoadjuvant or adjuvant therapy. Pathological staging, it is based on surgical resected tumor tissue and systemic lymph node dissection and sampling, which include mediastinal lymph node involvement. Determines all staging parameters based on surgical finding, and it also allows a multidisciplinary team to confirm the adjuvant treatment approach. And the next is how management has changed over a time. We can see the diagnosis of lung cancer, then after it is converted into non-small cell lung cancer and histological breakdown like squamous cell carcinoma or non-squamous cell carcinoma, large cell and adenocarcinoma. Thereafter, there is a molecular pathology which depends on the EGFR and ALK and ROS1, and tumor mutational burden, which is less than or is equal to 10 mut per MB. And thereafter, there is a treatment in which there is chemotherapy and radiation is involved, and targeted therapy is involved, immunotherapy is involved, and combination of various therapies are involved. Advances in management of lung cancer has improved survival. We can see the survival rate has been increased, and lung cancer, it is a specific survival improved from 26% among men with lung cancer that was diagnosed in 2001, and it extended to 35%, and among those in whom it was diagnosed in 2014. And thereafter we can see the reduction in the incidence along with treatment advances, mostly particularly approvals for and use for targeted therapies. Advances in treatment of non-small cell lung cancer, early and late stage, targeted and immunotherapy. We can see a significant increase in approval of both targeted as well as immunotherapy in lung cancer, which is seen as like a drug crizotinib for ALK positive lung cancer, which was in 2011 August, and thereafter erlotinib for EGFR positive lung cancer, which was in May 2013. And thereafter we can see Jeftinib for EGFR positive, which was noted in 2015, and thereafter Crizotinib for ROS positive lung cancer, which was noted in March 2016, and Cartinib for ALK positive lung cancer, which was noted in July. We can see the data over here of the drug and its advantage and benefits, like Capmatinib for MET positive lung cancer, which was noted in May 2020, and sulfatinib, which is for red positive lung cancer, which is also noted in May 2020, and brigatinib, which is for ALK positive lung cancer, which is also mentioned in May 2020. So we can see the data over here of the drug and its advantage of the drug. And thereafter, molecular target in lung cancer. The molecular profiling of lung cancer has identified many alterations and their subtype. Like all patients of lung cancer should undergo molecular profiling to identify targetable alteration, like molecular complexity of adenocarcinoma. And there are 7 molecular alterations with FDA approved targeted therapies, which involves EGFR, ALK, ROS1, BRAF, V600E, and NTRK, and MET, exon 14, and RET. This increased the need of molecular testing for lung cancer. And we see the molecular testing should be a standard of care in lung cancer. Thereafter, targeted therapies, which are improving outcomes in advanced lung cancer. We can see 50% of patients with advanced non-squamous lung cancer will have a driver mutation targetable with an FDA-approved agent or on a clinical trial, like a FLORA PFS with a first-line osimertinib versus first-generation EGFR TK1 in advanced EGFR and non-small cell lung cancer. We can see over here osimertinib and its data and its ratio, and its first generation EGFR, its data and the ratio. And thereafter, we see the ALEX PFS with first line alectinib versus crizotinib, advanced ALK plus lung, non-small cell lung cancer. So we can see here chemotherapy and the medians of PFS, which is 5 to 7 months with EGFR, and this has increased to 18.9 months, and with ALK inhibitor, which is 13.8 months. Alectinib has increased OS significantly in positive non-small cell lung cancer. We see here five-year OS rate of 62.5%, and median OS, which is equal to not reached, and thereafter we see stage 4 non-small cell lung cancer patient, especially one with targetable mutations, which may now survive for almost 4 to 5 years. Survival outcomes with targeted therapy in advanced non-small cell lung cancer. We can see here non-squamous and squamous cell lung cancer, and EGFR based, and RAT based, and TRK based, which are given with the drug like a platinum doublet, which is continued for 4 months, and thereafter it continued for 8 months. And so we can see the uh, uh, squamous cell cancer and its time period, and for its prognostic time involvement for a prognostic of a disease. And with recent advances, survival rate are improving compared to chemotherapy alone. Immunotherapy in lung cancer, immune checkpoint inhibitors like CTLA4 blockade, which work on dendritic cell and on T cell, in which body own immune cell started to fight with cancer by activating signals like antigen, MHC antigen, which bind with TCR, and B7, which bind with CD28, and thereafter we see B7, which also bind with CTLA4, and TCR antigen, which bind with MSC, and PD1, which bind with PDL1 and PDL2. So we can see here the mechanism of immunotherapy in lung cancer, in which there is immune checkpoint. The next is approval for ICI over time. We see here the data in which 2015, there was a drug, pembrolizumab, uh, which is with PDL1 TPS, and which is equal to or more than 1%, which is post PLT based CT, and then it converted into nivolumab, which is also post PLT containing CT. And so we can see the data over here, like in 2017, pembrolizumab, which work on non-squamous cell lung cancer, and in 2019, atezolizumab, which also work on non-squamous cell, and which work with a drug like carboplatin and nab-paclitaxel. And after that, we can see in 2021, samiplimab, which also work for lung cancer, non-small cell lung cancer, with ineligible for resection and definitive CRT with PDL1 and TPS, which is equal to or more than 50%. So we can see here the data in which how drug act with squamous cell and non-squamous cell lung cancer, non-small cell lung cancer. And we see here the survival outcome with ICI, in which historical non-squamous and squamous cell lung cancer. We see here the time period like platinum doublet, which is for 4 months, and thereafter it continued further over for 8 months. So we see here immunotherapy based on histology, and histology PDL1, and immunotherapy which based on PD-L1 on any histology. So here we see checkpoint inhibitor which have improved survival in advanced non-small cell lung cancer. There is a keynote which show an improved survival in patient. So we can see here the graph here which show the uh, increasement and prognosis of disease with drug like pembrolizumab, uh, which is compared to chemotherapy with PD-L1 and TPS, which is equal to or more than 50%. And now we see a checkpoint inhibition, which is moving to early stages, unresectable stage third, non-small cell lung cancer. Immunotherapy in stage third, it is a Pacific trial. Generally, it is a Pacific trial, which is a randomized, double-blind, plus placebo-controlled phase third, and trial of consolidation and durvalumab in unresectable non-small cell lung cancer. So we see here durvalumab demonstrated 42.9% OS at 5 years, and in comparison to other histological OS, which is unresectable in stage third non-small cell lung cancer, which is of a time period of 5 years, and the percentage is between 15 to 25. And what is new in non-small cell lung cancer? So here is the mechanism of action, like antibody drug conjugate. Firstly, ADC goes and bind with antigen, and thereafter internalization with endocytosis. Uh, it goes and bind with antigen, and thereafter degradation of ADCs in lysosomes, and thereafter release of payload and drug action, and after that apoptosis of targeted cell, and it is mostly approved for breast cancer. So thank you so much.
Thank you, sir, for this such an informative talk. For the next talk, I would like to invite Dr. Nitin sir for his talk on exceptional response to osimertinib EGFR metastatic NSCLC. Over to you, sir.
I am audible.
Yes, sir, you are audible.
My screen, I can't share the screen actually. Okay, let me check once now. Is the screen visible now?
Yes, sir, it is visible.
Okay. So good evening, everyone. First of all, I would like to thank Dr. Ajay Sharma as well as the organizing team of AstraZeneca for inviting me for this talk. So I'll be today talking about a few clinical case studies as well as anecdotes about exceptional response of osimertinib in EGFR mutated metastatic non-small cell lung cancers. So as we all know, the paradigm shift in treatment of lung cancer happened over the last 10 years, last decade, where the treatment have moved from blanket chemotherapy to targeted therapy. And the main game changer in this was EGFR TK and especially osimertinib. So we have discussed about the response of osimertinib in metastatic lung cancers earlier. So I'll be discussing a few clinical cases. So the first case, in October 2020,
Excuse me, sir.
Mr. X, a 64-year-old gentleman, was presented to the
Sir,
clinic
sorry
with
to
cough.
disturb, sir. Sir,
Sorry,
your slides are not moving. Actually, your Chrome screen is visible, not your slides.
just a minute.
Yes.
Share the slides again. Do you have the slides with you?
Yes, sir.
Just a minute.
Tech
Is it,
support,
is
can
it,
you please?
is it visible now?
No, yes, sir, it is visible now.
Okay. It's moving, right?
Yes, sir, it is moving.
Okay. So Mr. X is 64-year-old gentleman who presented with cough, progressive breathlessness, and severe backache. He could not walk without support for the last 10 days, and history of giddiness for the last 1 week. Weight loss of almost 5 kgs in last 1 month, and personal history, he was a non-smoker. On evaluation in PET scan, there was a large mass around 4 into 3.2 centimeters in the right upper lobe, as we can see in the image, with hilar nodes and multiple bone metastasis. Biopsy was done as well as further molecular analysis was done, and biopsy was suggestive of adenocarcinoma with IHC markers suggestive of the same. And on molecular analysis, the patient had EGFR exon 19 mutation positive as a driver mutation, and rest other mutation like KRAS, BRAF, MET, everything was negative. PDL1 was also negative. And MRI brain was done at baseline, which shown multiple ring enhancing lesion in cerebellum and cerebral hemisphere with significant perilesional vasogenic edema. As you can see in the image, there are multiple lesions with a lot of edema. So the final diagnosis was stage 4 non-small cell lung carcinoma, EGFR mutated, exon 19 deleted with mets in brain as well as bone. As we discussed earlier at the presentation, patient was symptomatic. He was unable to walk and he had history of back pain. So we started the patient on anti-edema measures as well as supportive care. And he was advised radiotherapy for the brain metastasis because he was symptomatic, as well as was started on EGFR TKI to target exon 19 deletion. So treatment of patients with metastatic EGFR mutated non-small cell lung carcinoma. After the advent of EGFR TKI, we know that there are multiple generation of TKIs that have came up into the market. The first generation include mainly geftinib, erlotinib, afatinib, second generation dacomatinib, and third generation osimertinib, which is a predominant game changer in treatment armamentarium of metastatic non-small cell lung cancer right now. So these were the comparison between various studies which was done in patients with metastatic NSCLC, and geftinib, erlotinib, afatinib, dacomatinib, the respective studies, they compared with the platinum doublet versus TKI, and the median progression-free survival in case of geftinib, it was around 9.5 months in IPAS trial, erlotinib 13.1 months in optimal trial, and afatinib, it was Lexlung 7, which shown 11 months. Dacomatinib, it was Archer trial, which shown about 14.7 months, and osimertinib, it was Flora trial. And we have discussed in many the Flora trial many times, and that have shown a remarkable response with an improvement in PFS to about 18.9 months, which is actually quite impressive. So since then, the first line of treatment for metastatic lung cancer, unless the patient is not affording, is osimertinib. So degree of CNS penetration for osimertinib. So another important point about osimertinib, other than the efficacy and the response rate and improvement in PFS and OS, is that they have very good CNS penetration with a very good marked improvement in CNS PFS as well as CNS response rate. So these were the studies, pharmacokinetic studies, which were done to compare the response of osimertinib and other first generation TKI especially in case of CNS disease. So for a dose of 25 milligram per kg of osimertinib, the brain to plasma ratio, as we can see, was 3.41. That was as compared to plasma, there was 3 times more distribution of the drug in brain. On the other hand, in case of geftinib, it was 0.21, and afatinib, it was less than 0.36. So this was another study which was done in normal individuals who didn't have any metastasis to brain or didn't have any lung cancer. And this was another pharmacokinetic analysis where carbon-11 tagged osimertinib was given to 8 subjects to see the distribution of the drug within the brain. And was found that within 30 to 40 minutes, majority of patients achieved drug distribution throughout the brain, even with an intact blood-brain barrier. This was another study which was later published, and this again was done in patients with brain metastasis. So in the first image, we can see that at the baseline, PET1 on day 1 baseline before giving osimertinib, these black circles shows the lesions within the brain. And on day 2, 6 hours post giving osimertinib, we can see that carbon 11 osimertinib distribution is seen as yellow uptake within the brain. And in day 22, we can see that most of these lesions have reduced in size. The black circle shows the initial lesion, while the pink one shows the new size of the lesion. So majority of lesions have reduced in size and few of them have even disappeared. So currently, management of EGFR mutated non-small cell lung carcinoma with CNS mets, the first line of treatment is osimertinib unless patient is symptomatic. So if newly diagnosed case comes and patient is symptomatic, then definitely we'll have to give supportive care as well as local therapy in the form of SRS or surgery, decompressive therapy. And on the other hand, if the patient is not symptomatic, we can directly start the patient on osimertinib. On the other hand, if at all patient has been started on first and second generation TKI, which is not very common nowadays, unless the patient is not able to afford, then again, if the patient develops a progressive disease in the brain and patient is symptomatic, we'll give, and CNS progression is patient if symptomatic, then we give a local therapy like SRS or surgery, and we'll change the TKI if there is a systemic progression as well. If it is CNS progression alone, we can give the local therapy itself and continue the same TKI. We should always look for mutation analysis in the metastatic lesion, and if T790M is positive in liquid biopsy or in the new metastatic site of progressive disease, then we'll have to switch the patient to osimertinib. So this is the FLORA trial results and especially the brain outcomes. So what we can see is that those patients, the overall, the total patients who had both non as well as who didn't have any non-CNS metastasis, initially when the osimertinib was compared with geftinib or erlotinib, they had a marked improvement in median PFS, as we can see, with 15.2 versus 9.6 months with a hazard ratio of 0.47. And those patients who didn't have any non-metastasis and only non or treated CNS, who didn't have any baseline metastasis, CNS metastasis, they had marked better response with 19.1 versus 10.9 with a hazard ratio of 0.46. So this is again comparison between trials of various TKIs, especially with respect to their CNS response and CNS progression-free survival. In afatinib, Lexlung 3 and 6, we compared it with chemotherapy, while in Lexlung 7, we compared with geftinib. In both the cases, it was found that in afatinib, those patients received afatinib as compared to chemotherapy, they had improvement in CNS PFS, but those patients who had afatinib versus geftinib, there was no difference as such in CNS PFS between both the TKIs. Dacometinib Archer study, there was no patient with CNS metastasis were not included in the study. For osimertinib, FLORA trial, we compared it with geftinib and erlotinib. Those patients who had asymptomatic CNS metastasis, they had CNS PFS was 15.2 versus 9.6 months. Well, those patients who had asymptomatic CNS metastasis, but at baseline, they had some scans done and there was metastasis, measurable disease was there. In those patients, the response was very marked with a 66% response for osimertinib as compared to 43% with first generation TKI. And the median CNS PFS is not yet reached in patients with osimertinib as compared to 13.9 months in first generation TKI. So for this patient, for bone metastasis, we gave palliative radiotherapy as well as zoledronic acid was started. For brain metastasis, patient was not willing for brain RT. So we started her on osimertinib 80 mg per day. The follow-up PET scan was done after 4 months in March 2021. So the initial scan shown primary lesion within the lung decreased more than 50% reduction in the size, and right hilar as well as paratracheal lymph node also decreased in size more than around 60 to 70%. So this is another comparative analysis where the effectiveness of TK in brain metastasis was assessed. And as we can see, as compared to first generation TKI, for osimertinib, the median CNS duration of response is also not reached yet. While for erlotinib, geftinib, it is 14.4 months, and objective response rate was 66% versus 43%. And also, in these same patients, when they had a baseline evaluable disease or evaluable measurable disease was there, and then evaluable response was taken, then again the objective response rate was 91% versus 68%, and duration of response was 15.2 versus 18.7 months. So again, for the patient we were discussing, we got a follow-up MRI done in February 2021, almost after 3 months, and the lesions have almost disappeared. And again in July 2021, patient had complete resolution of brain lesions on MRI brain, and no further interventions was indicated. So that was the first case. And another case where a 53-year-old patient who had lung cancer resected, and he was undergoing chemotherapy, but the patient relapsed during therapy, and subsequent scans revealed pretracheal nodes with hypermetabolism and brain shown multiple brain metastasis, with largest one 3.1 centimeter in the cerebellum, especially in the inferior vermis, and marked edema. So and for this patient also, again, we started him on 80 milligram of osimertinib. And for ataxia, we did craniotomy was scheduled, and tumor resection the following week was done. So the multiple case reports have been, we can find a lot of case reports where the patient have shown remarkable marked response with the osimertinib alone, even without any local therapy in cases of EGFR mutated lung cancer. This is one of such study where a 75-year-old female with stage 4B lung adenocarcinoma with EGFR mutation and lung mass, multiple lung as well as brain mets were treated with osimertinib. And after 5 weeks, the multiple brain mets disappeared completely. She had a complete response together with response in the lung lesion. This is another study which was actually published in Neuro-Oncology study, where it was 3 arms were there. It was a phase 2 study, 3-arm prospective trial, where the patients with EGFR mutation, those who are treatment naive, was given osimertinib. Those patients who had earlier received EGFR TKI were given the same osimertinib, and another patient with Rheonin 790 met T790M positive or negative were also being given the same therapy, and it was found that the objective response rate was marked for those patients who were treatment naive with osimertinib with 84%, 66% for those patients who were already on EGFR TKI, and was only 50% for those patients who were T790M positive or negative. The exact data about that number of patients and the response with those patients who were positive or negative is not being given, but overall it was around 50%. And the disease control rate was 94.7%, 94.4%, and 80%, 80%. The median PFS was 11.8 months for those patients who were treatment naive, 7.6 for those with EGFR TKI, and 6.3 for the group C. So the osimertinib demonstrated high efficacy on brain metastasis in all the trial arms. So this was the patient we discussed earlier who had a relapsed lung carcinoma with brain metastasis. So on follow-up PET scan, there was complete response by April 2022. In November 2021, it was a partial response, and by April, patient had a complete response for the primary disease. So the discussion key points and the food for thought: radiotherapy right now is not indicated for all the patients. Only those patients who are markedly symptomatic, we can go for radiotherapy or surgery. Otherwise, the best line of treatment for any patient with EGFR mutated lung cancer with brain mets is osimertinib at first line itself. Almost complete resolution has been seen in many of the, most of the cases we have seen complete resolution for the primary as well as the nodes. No adverse events were reported in these patients. Patient remains progression-free for almost 19 months after initiating osimertinib. So the patient is fully active, goes for morning walk and yoga sessions. So the food for thought is this: if a patient presents with EGFR mutated lung cancer with brain mets, the first line of treatment is osimertinib. Even without brain mets, the treatment of choice is osimertinib currently. Excellent response to osimertinib. Are such tumors different? Thank you. That's all. Hello.
Thank you, sir, for the amazing talk.
Okay.
Now for the closing and thank you, I would like to invite Dr. Ajay Sharma, sir. Sir, please, your thoughts, please.
Thank you. First of all, thank you, Nitin, for the wonderful information you have given. And thank
Thank you,
you,
sir.
Dr. Madhu. Thank you, Dr. Madhur and Dr. Nishant. So excellent talk. Although you are very wise for these things, but still, I applaud for you for your confidence and the extensiveness you have shown in your slides. So keep it up. And very rightly said. So this is an era of genetics. This is an era of individualized and tailored medicines. So I think message goes that don't jump for chemotherapy, especially in the lung cancers. And there are so many cancer others also, like breast cancers, we can say. And we should wait for the proper reports until unless there is any visceral crisis, there is any emergencies. So we have to wait for the needed genetic testing, and after the complete testing only we should go for the treatment, because it is the treatment which has to show the response to the patient, and that makes us happy. Isn't it, Dr. Nitin?
Yes, sir. Yes, sir. Absolutely.
So great, great job by all of us. So I think we will continue with the next thoughts. And in the meantime, again, a thanks of note to AstraZeneca and all my colleagues. So thank you. Have a great evening.
Thank you. Thank you, everyone.